All right, thanks everybody for joining us. We'll go ahead and get started. This is Patrick Hall with CancerBridge, and we've got Dr. Cassandra Grenade ready to present our topic, cancer prevention and screenings. I just kind of want to do a couple housekeeping items up front. We'll be doing a Q&A at the end of the webinar. We think the presentation will be around 30 minutes or so, and we'll have 10 or 15 minutes at the end set aside for any questions. You can ask your questions via the GoToWebinar questions panel inside the application, and I'll direct those to Dr. Grenade at the end. And then I just kind of want to spend a few minutes here at the beginning talking about what CancerBridge is. CancerBridge is a cancer-focused navigation service that provides you with immediate one-on-one personalized access to a physician like Dr. Grenade, who's an expert in your specific type of cancer, be it expert guidance to you and your family at a time of uncertainty. Thank everybody for joining this webinar, as well as your employers, the companies that provide this service to their employees. This is a benefit that we're going to try to extend to you every 3 months or so, to arm you with more information about cancer prevention, and general education about cancer issues. When you and your family call CancerBridge, you'll talk to someone knowledgeable who'll listen. Again, you'll get rapid access, typically within 24 hours, to have a conversation with an expert in your specific or your family member's specific type of cancer. And that physician can give you very specific understandings about the cancer issues that you're facing, as well as help provide guidance around next steps and help you avoid any mistakes or navigation errors during your cancer journey. So again, we provide immediate answers during a time of crisis. So to learn more about CancerBridge, you can go to mycancerbridge.com or speak to your HR representatives about the service. So with that, I'm going to pass control of the presentation over to Dr. Cassandra Grenade, who is a medical oncologist at the James Comprehensive Cancer Center.
All right, good morning, everyone. Thank you, Patrick, for that introduction. So today's webinar, we're going to talk about cancer prevention and screening, and we're going to focus on the main cancer types, which includes breast cancer, prostate cancer, and lung cancer. As Patrick said in the introduction, I'm a medical oncologist at Ohio State University James Cancer Hospital, and we thought this topic would be helpful to everyone because there have been some recent changes in terms of cancer screening guidelines, so we'll review those briefly today. We'll first start off with breast cancer. So as I mentioned, we'll talk about breast, prostate, and lung cancer. So breast cancer is the second leading cause of cancer death in women in the United States. It is projected in 2016 that 1 in 8 women, which is about 12% of the U.S. population, will be diagnosed with invasive breast cancer at some point during their lifetime. In 2016, we expect to diagnose almost 250,000 cases of newly diagnosed invasive breast cancer. And out of those cases, approximately 41,000 women will die of their breast cancer. So as you can see from these numbers, a quite significant number of patients are diagnosed, but thankfully not as many die from the disease. And this is a graph that we commonly use in presentations like this, and this is taken from American Cancer Society. And this is looking at the estimated new cases of cancer diagnoses for 2016. And then the bottom here is estimated deaths for 2016. And if we were to just focus at this point to breast cancer, because I'm going to use this graph throughout the presentation, again, we see that breast cancer is the leading cancer diagnosis in females. About 30% of all cancer diagnoses is breast cancer. About 200 and almost 50,000 patients will be diagnosed with breast cancer. and we're looking at a mortality of about 40,000. If we put our attention to the graph to the right, 75 to 2012, that the incidence of breast cancer has actually now stabilized a little since the advent of screening with mammograms. So our diagnosis of breast cancer has now stabilized, and our mortality has actually decreased. So just focusing on the breast cancer graph. So what are some risk factors for breast? In terms of risk factors, there are risk factors that we can control, and there are the ones that we cannot control. And we tend to name the ones that we can modifiable, things that we cannot change. So that includes our gender. Of course, females are at increased risk for breast cancer, more so than males, but I wanted to take this opportunity to point out that 1% of breast cancer is diagnosed in males, so it's not something that is only inclusive of females. So 1% of males breast cancer is diagnosed in males. So your gender, your sex, male, female, that is something that you do not have control of, and that being a female increases your risk for the disease, obviously. Age, as in most cancers, cancer increases as one ages. So age is also a risk factor for breast cancer. We can see that younger than 45 years of age, it is estimated that 1 in 8 women will be diagnosed with breast cancer. But as one gets older, greater than 55 years of age, that risk increases, and 2 in 3 women will be diagnosed with breast cancer. So age in itself is a risk factor, something that we cannot change. There are certain genetics conditions that increases the risk for breast cancer, and some of them, you might have heard of in the news and so forth. And those are genes that are inherited, that are passed down from family members, and that increases one risk for breast cancer. The most common one, and the one that is very well known, is the BRCA1 and the BRCA2 genes, and that is associated with breast and ovarian cancer. And I just wanted to point out, however, that the breast cancer associated with a genetic predisposition makes up the minority of breast cancer, only 5 to 10%. So if patients with these genetic variation diagnosed with breast cancer, in the whole scheme of all breast cancers, is only 5 to 10%. Now, certainly patients who have these mutations are at higher risk for breast cancer. Patients with BRCA1 mutation have risk factors of around 80% of developing breast cancer, 60% of developing ovarian cancer. So with the mutation, very, very high risk of developing breast cancer, but overall these mutations are in a minority of patients. A family history certainly increases one risk as well. So if you have one first-degree relative with breast cancer, that doubles your risk for the disease. If you have two first-degree relatives, that triples one risk for the disease. So this is pointing out that it's very important to know your family history, know what your parents have, what your siblings have, because ultimately there have been data that shows that if you have a personal history of breast cancer, so for example, you have been diagnosed with breast cancer of the right breast, that increases the chances of developing cancer of the left breast. And that is not disease recurrence, that is an independent sex self also increases your risk. And for those who like more numbers and kind of relative risk data, this is similar information presented in the table form. And again, the factors that we cannot control carry some of the highest risks: sex, age, genetic mutation, and personal history of breast cancer, greater than 4 times relative risk. Radiation is another factor that sometimes we do not control. For example, patients who have had a diagnosis of certain types of lymphoma at an early age, very common is the diagnosis of Hodgkin's lymphoma, usually with someone in their 20s, that a diagnosis and exposure to radiation before the age of 30 has been shown to increases one risk of radiation in the range of 2 to 4 times fold. In terms of risk factors that we cannot control, that continues to be race and ethnicity. We do know that African American women have a higher mortality rate from breast cancer, and interestingly enough, even though African American women have the highest mortality, so there's a disparity between the diagnosis and the mortality when coming to race and ethnicity. And that is in itself an entirely different and prolonged discussion, and it's a debatable discussion as to the etiologies for that disparities. But there are some that might lend to, in itself, inherent differences in the tumor biology between the race and ethnic groups, differences in access to care, economic access to care might then lead to some of these disparities. But again, very controversial and a discussion in itself. We do know as well that dense breast tissue, which is found on mammograms, that increases the risk of breast cancer, so increase 1 to 2 times previous chest radiation that I spoke about. And certain benign breast conditions, such as fibroadenoma, has been linked to a lower risk of breast cancer. In terms of modifiable risk factors, which means that things that you might have control of and can possibly change to lower your risk, these include nulliparity. That means not having children or having children at a delayed age. And the reason for this is prolonged exposure to estrogen. So we know that most breast cancer is hormonal driven, driven by breast and by estrogen and progesterone. So anything that prolongs one exposure to those hormones tend to increase the risk of breast cancer. So nulliparity, not having any children, means that you continue to have uninterrupted exposure to estrogen, and that increases one risk. Delaying the onset of when one have children, that also then prolongs you to a longer exposure of estrogen, that increases one risk. There was a very big national study that showed that hormone replacement therapy has been associated with a risk for increased breast cancer. That was used previously, more commonly in the past, for menopausal symptoms, and that has since fallen out of favor because of that study. Breastfeeding, again, also going back to the estrogen prolongation exposure, has been shown to decrease the risk, so meaning utilization of breastfeeding is associated with a decreased risk. There have been some data, although not 100% conclusive, that increased use of daily alcohol can increase one risk of breast cancer. And we do know that obesity and being overweight or being physically inactive, in studies where we looked at menopausal women, more so in menopausal women than premenopausal women, that has been linked with an associated risk of breast cancer. So in terms of breast cancer screening now, we kind of reviewed the general introduction and the risk factors. How do we screen for breast cancer? All the data that I'm going to use is using mammogram as the primary modality for breast cancer screening, which is the main way that we screen for breast cancer in the U.S. There are new and emerging techniques, including breast MRI, but I'm not going to refer to those. This is used in the primary way which we screen for breast cancer, which is what is recognized by all the national organizations with mammograms. So we do know that screening with mammograms is associated with a reduction in breast cancer mortality. This is of approximately 20%. And all the data that I'm referring to is referring to what we refer to as average risk women. So that is someone that does not have high risk features or risk factors for breast cancer. So no BRCA1 or BRCA2, no strong family history, all of those risk factors that I reviewed previously not included. So just the average risk woman that there is a benefit from screening with mammograms. And we do know that that benefit increases as one ages. So the older that you get, as we talked about, age is a risk factor for breast cancer and for cancer in general. So that benefit increases as one ages. And that's where the controversy really lies. I think no one disagrees that there is a benefit from screening with mammograms. The question becomes, when should we start screening? So if we were to look at the next slide, which is a summary of some of the breast cancer screening guidelines from 5 of the top organizations: American College of OBGYN, American Cancer Society, National Comprehensive Cancer Network, National Cancer Institute, and the U.S. Preventive Task Force. These are national and organizations that kind of set the stage for breast cancer screening and provide these guidelines. And there are variations between the different organizations, and hence what has led to the confusion in terms of what to do in regards to breast cancer screening. We focus on primarily 2, the U.S. Preventive Task Force guidelines and the American Cancer Society guidelines, which are national guidelines that sometimes help set the stage. American Cancer Society guidelines for breast cancer was just recently updated in October of 2015. And they have recommended that women starting at the age of 45 to on-the-go screening mammograms. This was a change from the previous guidelines where the age was from 40. Instead of 40 is 45. For women between the age of 45 to 54, they recommend annual screening. For women over the age of 55, they recommend a transition to biannual screening. That means every other year, and the opportunity to continue to screen annually if needed, if clinically necessary. Now, this is a very important point, that women should have the opportunity to begin annual screening between the ages of 40 and 44 if it is deemed medical necessary. If they have a discussion with their physician, their primary care physician, their oncologist, and there is a need, the American Cancer Society made it a point to say that that opportunity should be allowed. And that is an important point because as we talk more about these screening guidelines, there are always questions of whether or not certain screening procedures will be covered by insurance company if it comes out that a guideline says 45 years or 50 years. If you're 40 years, will that be covered? So most of the guidelines do have a general statement that says, based on clinical information, based on clinical scenario, that even a woman between 40 and 44 should be allowed to be screened. The American Cancer Society guidelines continue to say that women should continue screening with mammograms as long as they're in good health and they have a life expectancy of 10 years or longer. If someone has a life expectancy of less than 10 years, again, it becomes a discussion with your primary care physician or your oncologist. So just to put this in table form and comparing the new updated 2015 guidelines to the last time the American Cancer Society gave us some guidelines, which was in 2003, and we can see then that they have now changed the recommended screening time from 40, it was back in 2003, 40 years to start your annual mammograms, and now it is 45 to start your annual mammograms. And again, the opportunity should still be there for a woman between age 40 and 44. If you're over the age of 55, consider doing your mammograms every other year instead of annually. Most guidelines have also now removed and have not recommended the clinical breast exam or the monthly breast self-examination. That has led to any benefit or decrease in mortality or increase detection of breast cancer. So a lot of the guidelines have recommended that. And you can see that that is a change in 2015 compared to in 2003, where it was recommended for a certain age group that they do periodic breast clinical exam. So the U.S. Preventive Task Force, their guideline recommendations have also changed, and this actually came out quite recently, and they have now recommended an age of 50 to 74 for breast cancer screening guidelines. So previously, most of these guidelines used the age of 40, but now we just saw American Cancer Society have increased to 45, and the U.S. Preventive Task Force has used an age of 50 to 74. Again, the same kind of general statement is given that for women before the age of 50, the decision to have a mammogram should be something that is done weighing the risk and the benefit. Informed decisions should be made with the assistance of a medical healthcare provider. The U.S. Preventive Task Force for women over the age of 75 years and those older said that there is insufficient data to support the benefit of mammograms in this population versus the harm. And again, for this population is left up to a decision with your primary care physician. Just like the American Cancer Society, the recommendation against is removed, and monthly self-examination is removed. For women between the age of 50 to 74, if you do have to get screened, they recommend same thing, biannual screening for that age group. So why, has this occurred? Why, when we look at all the different organizations, do we see these differences in recommendations? And, that is a very controversial topic. I can say that if you talk to maybe 10 different breast oncologists or oncologists, you might get 10 different opinions. But some of the data leads to what's the number needed to treat. How many patients do we need to screen, the number needed to screen, how many patients do we need to screen with mammograms in order to save one life? And from, these recommendations are based on review of multiple studies, randomized multi-center studies, some observational studies. But in one study in particular that was published in the Annals of Internal Medicine in 2011, it was found that for every case of invasive breast cancer detected by mammogram in a woman between the age of 40 to 49, over 450 women had to be screened with a mammogram. 58 were recommended for additional images. So that means that of the 464 who were screened, 58 were then called back because additional mammogram with special images or ultrasound was needed. And 10 women were recommended for biopsies. And this estimate declined with age. So the number needed to treat, the number needed to screen was found to be that a very high number needed to screen in order to detect one breast cancer. And the other thing is that there are false positives associated with mammograms. In this study, they showed that screening every 2 years rather than every year reduces the cumulative incidence of at least one false positive test by 30%. So, some of this data is what supported transition from a annual screening to a biannual screening. In this study, we also saw that the 10-year cumulative probability of false positives, so meaning that you had a mammogram, they saw something, led to a biopsy. This was recommended 7% in someone who had an annual mammogram, and that decreased to 4.8% in someone who had a biannual. So these are mammograms that, saw something, you had a biopsy, and it was negative. So some of the recommendation, again, in the transition to biannual screening was based on some of this data. So if we were to, kind of look at the data more closely and look at the benefit to harm ratio or trade-off for a 10-year course of annual screen and mammogram for women between the age of 40, 50, and 60. So among 1,000 women aged 40 years undergoing mammograms over a 10-year period of time, we see that 0.1 to 1.6 women would avoid dying from cancer. So, in this age group, it's a lower number. As we move up for 50 years and 60 years, we see that it goes all the way up to 4.9 women would avoid dying from cancer. So as I said before, the risk of breast cancer, the risk of dying from breast cancer increases with age, and then therefore the screening benefit also increases with age. So for women 60, the greatest benefit, because more women in that age group will die from breast cancer and benefit from screening. So some of this data is what pushed for a later time period, age 45 versus 50, to start screening. And again, the same data could be interpreted by others as more of a need to screen early and to diagnose breast cancer earlier to prevent kind of more advanced disease as one gets older, but remains controversial. So in terms of breast cancer, I will conclude by saying that the decision will have to be an informed decision that you make with your physician, the decision to undergo mammograms. And this, again, is based on just the average population. It doesn't involve if you have a risk factor with a family history or previous breast cancer or previous radiation. Just for the average population, that decision to go undergo mammograms should be something made with your primary care doctor, with your oncologist, an informed decision. But most guidelines now have recommended either starting at the age of 45 or starting at the age of 50. Okay, we will switch gears to prostate cancer. So prostate cancer is estimated that over 180,000 new cases of prostate cancer will be diagnosed in 2016, and of those, about 26,000 men will actually die from the disease. 1 in 7 will be diagnosed with prostate cancer during their lifetime, and again, just like most cancers, it's really a disease of elderly men. 6 in 10 6 in 10 is diagnosed with men over the age of 65. The average age for diagnosis of prostate cancer is 66. Prostate cancer is the second leading cause of cancer death in American men, only secondary to lung cancer, and is averaged at 1 in 38 men will die of prostate cancer. Again, going back to our very commonly used chart from the American Cancer Society, we see that prostate cancer makes up 21% of all cancer diagnoses, estimated new cases in 2016. Again, over about 180,000 men will be diagnosed with prostate cancer. But, very interesting to note that when we look at the mortality, men who die of prostate cancer, even though this is the most commonly diagnosed cancer, when we drop down to, do men die of this? So this tells you that the majority of men diagnosed with prostate cancer will not die of their prostate cancer. They will most likely die of some other medical reasons, and men can live a very long time with prostate cancer. So the numbers here, shows that 20% diagnosed, but then the mortality is 8%. So what are some risk factors for prostate cancer? Risk factors for prostate cancer, again, include age. Age becomes a risk factor for just about every cancer almost, a non-modifiable risk factor. So as one gets older, that risk increases. Again, the average risk is mid-60s for a diagnosis of prostate cancer. Race and ethnicity is a major risk factor. We do know that African American men are more likely to be diagnosed with prostate cancer and also more likely to die of prostate cancer. And I would add also more likely to present with more advanced stage and more aggressive histology, higher Gleason score of prostate cancer than non-African American males. Again, a family history is quite important. So if you have a father or brother with the disease, similar to what we saw in breast cancer. There might be some genetic factors related to that, especially since there's a family history link, and more research is on the way to kind of elucidate that better. The role of diet and obesity and certain dietary lifestyles, such as red meat, is not quite clear. Some studies have shown a link and increased prostate cancer, and other studies have not. So that is not quite clear in the literature at this time, and it remains an ongoing area of research. So in terms of prostate cancer screening, and another controversial topic that has been in the news and in the media, the recommendations that we're hearing about is based on two major studies. One study called the Prostate, Lung, Colorectal, and Ovarian Cancer Screening Trial, PLCO, which is a really large trial that involved over 76,000 men. Men were aged between 55 and 74 years. They were initially followed for 7 years when the data was presented, and then followed longer for 13 years analysis. And what that study showed is that there was no reduction in prostate cancer mortality, so meaning, you know, death from prostate cancer from screening. So no reduction in prostate cancer mortality as a benefit of screening. Prostate cancer was detected more in the screening group versus the non-randomized versus the randomized to non-screening group, but again, it seems like the screening was not beneficial in that subgroup. And when they looked by different types, subgroups by age, comorbidities, or what your initial PSA was, they also saw no screening benefit. So this is one of the major studies. Now, this study has a lot of flaws. There are a lot of biases, and both studies that I'm going to talk about in terms of prostate cancer screening could be, you know, really analyzed and kind of taken apart. But these are the studies that lay the foundations for some of the prostate cancer screening guidelines. So from this one study, which was done in the U.S., a large study, no benefit or no reduction in mortality that was seen with prostate cancer screening. I refer to prostate cancer screening, I'm mainly referring to screening with a PSA, which is the blood test, and a digital rectal exam. And this study was actually PSA plus or minus digital rectal exam, so not all men were required to have that. The second study that makes some of these recommendations, so the European randomized study called ERSPC study, a very, very large study that looked at over 182 men. Study age 50 to 74. They were followed for 13 years, so comparable timeline to the American study. And they found that all-cause mortality was not reduced with prostate cancer screening. Prostate cancer mortality was lowered in the group that was screened, so this was opposite to the American study, but there were several differences in the way the study that was conducted that might account for the differences in mortality that we saw with this study and not in the U.S. study. But even though they did see a slight decrease in prostate cancer mortality, over 780 men needed to be screened to prevent one prostate cancer death in 13 years. So you had to screen quite a bit of men in order to prevent one death over a decade. So again, you know, this study had several biases and flaws. The way patients were randomized, the PSA cutoff. Again, this is a European study, not a U.S. study. Both of these studies, again, is applying to kind of average risk men. So like I mentioned, African American men are at higher risk for prostate cancer, and certainly a European study probably, not probably, I know, did not have a lot of African American men. So that becomes concerning when these recommendations then are applied to everyone. But I would say as well that in all of the recommendations, there's usually a fine line that says, you know, if you have high-risk factors such as a family history, certain race, ethnicity, that these recommendations do not really apply to you. So, you know, we talked about the fact that, you know, over almost 800 men needed to be screened to prevent one death. And you know, screening with a PSA then sometimes lead to biopsies, and there are possible complications with biopsies, even though it's relatively low. Initially, we quoted, you know, about less than 1% risk of infection and bleeding. Some studies have now found that that risk might be a little bit higher, but there's certainly a psychological component in there. So, you know, when one makes the decision to be screened, you have to be ready to accept what the results are. So that results might be that you have prostate cancer, but we don't need to do anything about it. That could be psychologically distressing. That can cause a lot of anxiety. That can come with some social stigma. So, you know, all of that has to be taken into account. Another reason for kind of revisiting the guidelines is overdiagnosis. So as I showed in the data, we do know that even though you know, hundreds and thousands of men are diagnosed with prostate cancer, that only about 26,000 are going to die from the disease, even though a greater than 180,000 will be diagnosed. So you know, this disease is clinically insignificant, or it can be clinically quiet for a lot of men, and not everyone needs to do a biopsy or have treatment or to be diagnosed. The lifetime risk of dying from prostate cancer has remained kind of relatively stable. I showed that 1 in 34 number before, and it has been pretty stable since PSA has become a common way of screening since the 80s. Overtreatment, so there are consequences to treating if you had prostatectomy or if you're treated with radiation therapy. You know, urinary incontinence or some side effects, sexual dysfunction. Again, I can put as well the social distressing factors and anxiety. That's all associated with that. So because of these findings, the American Urological Society has recommended no PSA screening in men under the age of 40. They also recommended no routine screening for men, referring to average risk men, not high risk. For men ages 55 to 69, the risk versus the benefit, you have to have a discussion with your primary care physician and review those and decide what to do, or with your oncologist. They recommend an interval of 2 years or more, so you don't have to do it annually, the PSA anymore. And for men who are over 70 with an expected life expectancy of less than 10 to 15 years, they recommend no PSA screening. So, you know, this is a big, you know, change in the last several years, where before we recommended PSA screening and digital rectal exam, now is no longer recommended by this organization. The American Cancer Society takes a more conservative approach to it and says that the decision should be an informed decision made between the patient and their medical provider. For men who do decide to get screening based on the decision that they make with their primary care physician or with their physician, they recommend that screening begin at the age of 50 and not to do if the life expectancy is less than 10 years. The United States Preventive Service Task Force, they actually just came out and said that men should not be screened. Based on the 2 studies that I presented, they do not recommend annual screening or even biannual screening for men for prostate cancer. So with the PSA and the DRE, they believe that the screening harm, the benefits of screening does not outweigh the harm, and the harms is, you know, all the things that I spoke to you about, biopsy risk, overtreatment, all those things. But obviously, all of these guidelines is ultimately left up to informed decision making with one primary care provider. So switching gears now to lung cancer briefly, as we coming up on time. So lung cancer is the most common cause of cancer worldwide. And I wanted to make sure that I included lung cancer because I know most people, or a lot of people, don't even know that we have a screening test for lung cancer. It is the leading cause of cancer-related deaths. So I'll show you that nice figure again, and we can review between breast, prostate, and lung that more men die of lung cancer, more people die of lung cancer than any other cancer. It is projected that over 117 cases will be diagnosed in 2016, and as you can see from that 117 cases that will be diagnosed, over 85,000 patients will die of lung cancer, so high mortality rate. So again, reviewing this figure, we see that lung cancer accounts for 14% of cancer diagnoses in men and 13% of cancer diagnoses in women, but the mortality is the #1 cancer mortality for men and women, accounting for about 27% estimated deaths in males and 26% in females. So not the most commonly diagnosed disease for females, but certainly the highest mortality. And same thing for males. And look, if you were to just look at, the mortality from lung cancer compared to prostate, colon, pancreatic is almost triple. And same thing for breast cancer, doubled. So what are some risk factors for lung cancer? The primary risk factor for lung cancer is smoking, tobacco use. That is the #1 risk factors. But other environmental exposures as well, asbestos exposure, Agent Orange, for someone who had prior radiation to the chest wall. This, among some other risk factors, can increase your risk for lung cancer, but smoking is the primary risk factor. So in terms of lung cancer screening, yes, we do have a screening test for lung cancer, and I hope that after this presentation that some of you ask your primary care physicians about that, just like how you get your cholesterol screen. If you meet these criteria, lung cancer screening is one that you should have a discussion about, and it is covered by insurance. So there's a large national study called the National Lung Screening Trial, and that showed that from low-dose chest CT, there's a 20% relative reduction in lung cancer deaths, almost 7% relative reduction. So there's a clear benefit in lung cancer screening in terms of reduction in mortality and deaths for lung cancer screening, which we do not have, like, for example, like in prostate cancer screening from the data that we have. So screening with low-dose chest CT has been shown to decrease lung cancer mortality, and this is the recommendation from the U.S. Preventive Service Task Force. Anyone age 55 to 80 with a history of smoking. You can get an annual, so once a year, low-dose CT scan. If you have a 30-pack year smoking history, so 30-pack year means that you smoke 1 pack per year for 30 years, or you smoke half a pack a year for 60 years, that gives you 30-pack year. If you're currently smoking and you meet this age group, if you've quit within the past 15 years, but you meet any of these criteria, then you can be offered lung cancer screening that will be, part of your regular physical exam workup. Screening should be discontinued once a person has not smoked for 15 years or developed health problems that substantially limit their life expectancy. Then you don't have to screen. But if you meet any of these factors, 55 to 80 years old, history of smoking, 30-pack year, you quit within the past 15 years, you qualify for screening with an annual low-dose CT scan for lung cancer. And again, shown to really decrease the mortality. The goal of most screening tests is to early detection of cancer. So if we're able to detect cancer at an early stage, stage 1 and stage 2, where it's more curative than more advanced stage 3 and stage 4. I will just summarize by saying these are my references. I use UpToDate and thecancer.org. I would just summarize and conclude by saying that all of these screening guidelines and recommendations, ultimately involves an informed decision-making between patients and their medical provider. Hopefully today you get some information that will stimulate that discussion and encourage that discussion as you move about, you go about asking questions for breast, prostate, and lung cancer screening. So I will conclude at this point, 11:47, and we will take any questions that you guys might have.
Yeah, Dr. Grenade, thank you so much for all of that information. That was incredible. I know that I think like most of the people on the presentation, I just feel very fortunate that we have access to somebody like you with your expertise to help us navigate these problems. If you've got any questions, please ask them through the GoToWebinar questions panel. So I'll start running through some of our questions with Dr. Grenade now. We've got several coming through. Dr. Grenade, in your slide that you had the breakdown of cancer rates and mortality, we saw that brain and nervous system cancers accounted for 3% of deaths, but it was not in the chart for estimated cases. Is that a type of cancer that's not easily diagnosed?
What was the second part of the question?
So the question is, I see that brain and nervous system cancers account for 3% of deaths, but it's not in the chart for estimated cases. Is it not easily diagnosed?
So I'm sure she's referring to this slide here.
Yep.
Okay. So brain and, and estimated 3% of that. That just means that of the new cases diagnosed for brain and nervous system cancers, that it was not like in the top 10. It was not in this list. So it's lower than this 3% that they use for cutoff. So, you know, brain and nervous system cancers are very rare tumors. So we're talking about, you know, 1 to 2% of cancer diagnosis, or even less than that. But yes, when they are diagnosed, they have sometimes a higher mortality, and that's why it got into the deaths rate. So overall, these cancers and these cases are rare. So, stoma or certain brain tumors, you're in the 1% or less range for diagnosis. So that's why.
Okay, thank you for the clarification there. And we've got a couple questions around, you mentioned a couple times family history as a risk factor.
Yeah.
So one of the questions was, kind of what are the generations or what are the relationships that do matter when thinking about family history? And then kind of a follow-up question that's similar to this is specifically around screening for pancreatic cancer. If you're a female and your brother has had pancreatic cancer and you're both in your 50s, should you be screened as well? So I think there's, maybe if you could clarify around what types of family history matter there, and then maybe discuss a little bit around pancreatic cancer if you could.
Yes, so that's a good question. So most risk factors that we know related to cancer and family history is at this time limited to first-degree relative. So a first-degree relative includes your parents, a sibling, offspring, usually not like a grandparent or not, or something like that. So first-degree relative. In terms of pancreatic cancer, we do know that there is a genetic predisposition with pancreatic cancer that accounts for, a smaller percentage of pancreatic cancer. So if there's a strong family history of pancreatic cancer, a brother, another family member, first-degree relative, then I would recommend that that individual have a discussion with a genetic counselor. The majority of cancers, just like what I showed for breast cancer, is not related to any kind of genetic predisposition or family history link. Most cancers are what's called sporadic cancers. It just happens. But if there's a strong family history of pancreatic cancer with no other risk factors, so, there are risk factors for pancreatic cancers as well. So, someone with chronic pancreatitis or obstruction of the pancreas or, some other factors that probably increase their risk for pancreatic cancer. But if there isn't any, and not just one family member, if there is several family members that repeatedly get the pancreatic cancer, yes, and have a discussion with someone about seeing a genetic counselor.
Okay, great. And then I'd like to just remind everybody, if you do have questions around specific scenarios like that, please contact our CancerBridge service as well, so that we can kind of help you dig into the specifics of those scenarios. That's a resource that is available to you. But thank you.
Yeah, that would be like a great question for CancerBridge, because then we can get more information about the family history, the age of diagnosis. That's another key. So, even for breast cancer, it's not only first degree relative with the disease, but when were they diagnosed? It makes a difference if they were diagnosed earlier versus later. So these are all things that we will be happy to help with on CancerBridge.
Yeah, exactly right. Thank you again. So we've got a couple questions around prostate cancer. So I'm going to try to maybe we can address these together. So it seemed as if in your information that diet wasn't a factor in prostate cancer prevention. So are there any lifestyle factors that can be controlled, or is it purely genetic and family history that's contributing there?
Yeah.
And then when it comes to screening, so I think the person got the impression that if prostate cancer screening isn't recommended, is the alternative then simply someone with undetected cancer to have to experience some type of pain and suffering before they seek treatment? So if you can maybe address if there are any additional risk factors there, and then how to think about approaching when to get a screening.
Yeah. So, for me as a medical oncologist, there is no question, I think, that certain types of screening and screening for selective individuals have led to decreased mortality. The controversy lies in how often should we screen, when should we start screening, and should everybody get screened, as I reviewed. So again, I think if you have high-risk features for prostate cancer, family history, you develop urinary symptoms, your PSA, just doubled in 6 months, those kind of features, you certainly should be screened, and you should have a discussion with your doctor. So it's not a blanket statement for everyone, and that's why every recommendation will have, a paragraph where they say this is for average risk population. Not if you have high risk features or clinical symptoms, certainly you need to be diagnosed. But that is a concern. So one of the concerns that some oncologists have is that, because of these recommendations that have come out for breast and prostate, that may be in several years we will be dealing with patients coming with more advanced disease because we have not, been screening, and then we're going to miss a certain population and they come with more advanced disease. So that is the debate that occurs between oncologists. We go back and forth about that, and again, it will be left to an informed decision, putting all the data together with your doctor as far as what you should do with your risk factors. In terms of diet and lifestyle and obesity and so forth, the data is not conclusive. So there have been some studies that have linked high-fat diet with certain types of prostate cancer, and other studies that has not. So there's no clear evidence in the data, in the studies, in the literature, that diet, plays a significant role in prostate cancer. One cancer that I didn't talk about because I knew I was going to run out of time is colon cancer. And the data is a little bit stronger for colon cancer, where we do know that certain foods, red meat, high-fat foods, has been shown to a slight increased risk of colon cancer. But for prostate cancer, it's just not clear.
Okay. And then a follow-up question around prostate cancer. Is it possible for a male under the age of 50 diagnosed with prostate cancer, and what might those possible reasons be? I think you kind of addressed that question. But
oh yes, you can be diagnosed with. I have I have 30-something-year-olds with prostate cancer. So, you know, unfortunately, you can be diagnosed with the disease at any age. And that's why it's very important to know your family history. You know, ask your parents and brothers and siblings. No symptoms of an enlarged prostate or symptoms of something might be going on with your prostate. Those symptoms usually includes frequent urination, urinating frequently at nighttime, what's called nocturia, any urgency with urination or hesitancy with urination, difficulty initiating a stream, any changes in your urinary pattern, you want to discuss that with your physician. But prostate cancer could be diagnosed at any age, but for the most part, for the average population, it's a disease and its average age of diagnosis is mid-60s, average.
Okay, thank you for that. And then I think one final question, or a couple questions here around mammographies. So one of our questions was, is a mammogram the only way to diagnose breast cancer? And then another question is thermography better than mammography? So maybe if you could touch on those types of screenings, and then we'll wrap up.
What was the second part?
Is thermography better than, yeah, I'm not familiar with that term.
Yeah, so the main way in which we screen for breast cancer now is with a mammogram. There is more and more data using breast MRI, using 3D mammograms, using tomography, but those are not standardized as yet. So certain populations benefit from different studies. For example, women with dense breasts. So you had a mammogram and you were found to have a dense breast on the mammogram, then your screening a test moving forward will be better with a breast MRI. We're doing 3D mammograms are becoming more and more popular, but for the standard screening for breast cancer remains with a mammogram. Some of the newer method is not standardized as yet.
Okay, very good. Well, again, we appreciate your time, Dr. Grenade, and thanks for everybody who joined and asked such great questions. Please reach out to us at mycancerbridge.com or questions. You can send via email questions at mycancerbridge.com, and we can try to address anything that we weren't able to get to today. But again, thanks everybody for joining, and we'll go ahead and end the presentation. Thanks so much, Dr. Grenade. Very much. Thank you.
Thank you. Bye.